departments okay lah. That's nice. Five departments in one view. Okay. So I just have to attend one lah. So I just have to attend one lah. Okay. Oh yeah, true. Thank you. Ready for education.
Okay, I think we can start. Ada lagi yang tak datang?
Thank you.
Ada kelas ke sebelum ni?
Tak ada, doktor.
Ada, so why can't you be punctual at 9 o'clock the lecture kan? Okay, so the lecture today is on pathology of breast.
I thought it's a name.
It's also part of the reproductive pathology of the female tract. Okay, so what we are going to discuss in this chapter is on what are the common pathology in the breast. There are a spectrum of non-neoplastic pathology and neoplastic pathology. Okay, so the non-neoplastic pathology can range from those of congenital anomaly and those of inflammatory conditions, so-called fibrocystic changes that are now divided into non-proliferative and proliferative changes, and also the neoplastic pathology, which can occur in the breast, which can be benign and malignant. Okay, so the important features of the breast is that they undergoes periodic changes during adulthood, during pregnancy, and during menopause. And the lesions in the female breast are much more common than in the male. Okay, and usually they presented with palpable, sometimes painful nodules or masses. And most of the masses are fortunately benign. Okay, breast cancer. Having said that, breast cancer is, however, the most common cancer among women in Malaysia. Okay, so that's why it is not uncommon if you have a patient came to your clinic to seek an evaluation of even a slightly suspicious lump in the breast. Okay, so anatomically, the breast is a unit that has ducts and lobules. Okay, and these lobules, they contain acini and the stroma. And these acini, they are lined by the two layers of cell, epithelial cells. So we have the luminal epithelium and the myoepithelium. So this is a lobule, a breast lobule, and you have all the small acini forming tubules here. And these tubules are lined by both the luminal and myoepithelium. Okay, so the stroma, you have an intralobular stroma, which is within the lobule itself. So you have this connective tissue in between the acini. And then you have between each lobules, you have interlobular stroma. So there. just made up of this loose connective tissue to dense fibrous stroma. Okay? And these structures, these SC9, they respond to hormonal changes. So that means there will be changes during puberty, during menstruation, during pregnancy, and during menopause. Okay? Again, you have to note what are the lymphatic channels that drains the area of the breast, because it is very important, because when you have malignant changes, it will spread to the lymphatic channels and most commonly to the axillary lymph nodes. Okay, first let us look at the non-neoplastic pathology. Okay, first we have the congenital anomalies. So you have supernumerary nipples, which is an epidermal thickening that occurs along the midline from the axilla to the perineum. Okay, this is where the nipples grow. Okay, so that is the developmental progress. So you can have this persistent epidermal thickening along those midline. And the clinical significance of this is that they may undergo the cyclical changes and may give rise to painful or premenstrual enlargement along that line. And then you may have accessory axillary breast tissue, okay, in which you have breast, acini, and lobules inside the axilla. Okay, so this will also give rise to tumor. So tumor can arise from those lobules inside the axilla, and they can cause confusion with lymph nodes. Okay, and congenital inversion of the nipples. This is due to failure of nipple to invert during development, and they may correct spontaneously during pregnancy or by simple traction of the nipples. It may cause nursing difficulties, and it may confuse with changes due to inflammation or malignancy. Okay, for inflammatory conditions, you have acute mastitis, or they can progress to breast abscess. This may occur during breastfeeding. Okay, when you have cracks in the skin or in the nipple, it is vulnerable to the local bacterial infection, which usually caused by the Staph aureus. Okay. And they can be unilateral. They will show all the skin changes of inflammation, okay, erythematous, swelling, painful, tenderness, and patient may have fever. So if this progress further, it may form abscess. It can have multiple or single abscess formation with that. Okay. And if it's quite extensive, they may cause scarring, and they may mimic the neoplastic process, because it forms an irregular hard and firm mass. Okay, another condition, fat necrosis. Usually, in this condition, you have history of trauma or prior breast surgery, and it will present with an ill-defined nodule or lump. And on microscopy, you will see necrotic fat cells with macrophages engulfing the lipid. That's why you call it lipid-laden macrophages. A lot of neutrophils with fibrosis and calcification. So, because of the calcification, you may detect it during mammography. So, it may mimic tumor. Okay. Okay, so this dark bluish area here is the calcification. That is the empty spaces are the fat cells. Okay, and then you have periductal mastitis. This is painful erythematous subareolar mass, which is actually an abscess, and it may be complicated with inverted nipple, and it occurs among smokers. Okay, in recurrent cases, fistula tract can occur, and microscopically you will see granulomatous inflammation, and probably this inflammation is a reaction to a foreign material, which is the keratin shed from the squamous epithelium. Okay, the ductal lining actually becoming metaplastic. They change from the normal luminal columnar epithelium to the squamous epithelium in this case. right? And then we have mammary duct ectasia or the plasma cell mastitis. This is a non-bacterial chronic inflammation associated with inspission or breast secretion in the male excretory duct. Okay, so this occurs when the breast duct becomes dilated and thickened, so it leads to the blocked duct. And this dilatation and eventual rupture may lead to reactive changes in the surrounding tissue and can present with a poorly defined periareolar mass with nipple retraction. Okay, it is uncommon and it is not associated with smoking. And then we have lymphocytic mastopathy. So this may present with single or multiple heart masses, and this tends to occur among patients who has type 1 diabetes mellitus, the juvenile diabetes mellitus. Okay? And also it may be associated with some autoimmune condition, so thus it may have some autoimmune basis. Okay? And then we have granulomatous mastitis. So this can be a manifestation of a systemic disease, meaning it's a tuberculosis in other system elsewhere due to the tuberculous organism, or it can be due to a localized lesion, which is a granulomatous lobular mastitis. This is not due to tuberculosis. This is caused by hypersensitivity reaction to an antigen expressed during lactation. So the treatment between the systemic tuberculosis and the localized granulomatous mastitis is different. One requires the steroid, so the other one you need to treat the anti-TB treatment. Okay. Okay. So what are the benign disorders in the breast? Usually they do not cause symptoms, but during screening or routine mammography, you may detect it as calcification or some densities in the breast. So they are classified according to their risk of subsequent breast cancer. Okay. Most of them are not a precursor to breast cancer. So the term that is used for these changes are the fibrocystic change. Okay. And from the name, you know that there must be some features of fibrosis and cystic formation. So they are the most common changes or abnormalities that you see in premenopausal women. Okay, and the changes tend to arise during reproductive age, and most likely a consequence of the cyclic breast changes, okay, during the menstrual cycle. And any estrogenic therapy or oral contraceptive does not seem to increase the incidence of this alteration. And oral contraceptive even may decrease the risk. So this fibrocystic change, they are divided into two types, the non-proliferative and the proliferative type. The proliferative lesions are associated with some risk of malignancy, okay, especially those with some atypical changes. So when you have atypical hyperplasia, there is a risk of developing cancer. Okay, so for the non-proliferative pattern, it consists of cysts and areas of fibrosis. So morphologically, what you see are large cysts, can be single, can be multifocal, can involve both breasts, okay? And the areas will appear ill-defined or as increased densities or discrete nodularities on mammography. And the cysts may range from less than 1 cm to 5 cm in diameter. And they appear as a brown-blue cyst, blue dome cyst. So if you can see a bit of this bluish tinge on that lesion, and they are filled with watery turbid fluid, okay, and may calcify. So that's why they are detected on mammogram. So on microscopy, they will show cysts that are lined by flattened or atrophic epithelium, or the lining can undergo apocrine metaplasia, so they may show large polygonal and granular and eosinophilic cytoplasm. So the one on the right hand side here. Okay, so this is part of the cyst lined by those apocrine metaplasia. Okay, so this is another appearance of the fibrous area and the cystic lesion. Okay, so they may show some evidence of adenosis, just proliferation of the acini, cystic dilatation, the cyst, okay, and then you have areas of fibrosis. Okay, so this is the lesion. So brown, blue dome cyst. Okay, the next pattern of fibrocystic change is the epithelial hyperplasia. Okay, so normally the acini or duct, they are lined by these two types of epithelium. You have the luminal and the myoepithelium. Okay, so in epithelial hyperplasia, of course, the number of cell is increased. So that there should be more than 2 cell layers lining the acini. Okay. So, and the epithelial hyperplasia may range from non-atypical orderly type of cells to atypical hyperplasia that show some changes in terms of its sizes, pleomorphism, okay, and those things, alright? So, there are atypical and non-atypical changes. And macroscopically, they may not be distinctive. They may show areas of fibrosis or cystic changes. Microscopically, they may show spectrum of proliferative alterations. So the ducts can be filled with cells forming slit-like windows or fenestration like this one, or they can form papillary excrescences like a finger-like projection into the ductal lumen. Okay. And they may produce calcification, so they can mimic cancer. For atypical hyperplasia, just to show that it is hyperplasia, but the cells are showing atypical changes. Alright? And there are atypical ductal hyperplasia and atypical lobular hyperplasia. So both are increased in the risk of invasive cancer. Microscopically, they are formed by cells. Okay, they may show some pleomorphism, but most of the time they are monomorphic cells. So these are the cells that line the ducts or acini that show the changes. Okay, and then under the proliferative pattern of fibrocystic change, you have sclerosing adenosis. Okay, so in this type of lesion, they show less common cysts, but they show proliferation of the acini. Okay. And clinically, they can mimic cancer. They may show marked fibrosis and proliferation of small ductus and acini. Okay, so the lesion can be hard and rubbery, so that's why they may be confused with cancer. Microscopically, there are proliferations of duct luminous spaces, which is adenosis, but they are still lined by the 2 layers, the luminal and myoepithelial cells. Okay, and sometimes with the surrounding stromal fibrosis, it may compress the ducts and acini into a slit-like or cords of cells only. So histologically, it is difficult to distinguish from invasive cancer, but when you do stain to indicate the presence of the double layers of epithelium, then you know that this is benign. Okay, so the relationship of these fibrocystic changes to breast cancer is that there are risks of the proliferative type of fibrocystic change to risk of breast cancer. Okay, so when there is just fibrosis with some cystic changes and a little bit of hyperplasia without atypical changes, there are minimal to no increased risk of breast cancer. Okay? When there are moderate to florid hyperplasia without the atypia, and when you have sclerosing adenosis and ductal papillomatosis, there is slight increased risk, okay, about 1.5 to 2-fold increase. But when you have the atypical changes, atypical hyperplasia, there is a significant risk for breast cancer in that patient. So there is a high-fold risk of breast cancer. So when patient came into the radiology, they do mammography, the screening, you see classification, and normally you will do ultrasound-guided biopsy. The biopsy will be sent to the lab, and when the lab found out there is an atypical hyperplasia, then the patient has to be monitored regularly with mammography, okay, to see changes and increased risk for cancer. Okay, breast neoplasm. Okay, so this is a very important condition occurring in the breast. You have benign and you have malignant.
Who knows? It goes to the
neoplasm. And the changes may arise, this addition may arise from the epithelial component as well as the stromal component. Okay, the first one, fibroadenoma. So this is the most common benign neoplasm of the breast. It is a biphasic, meaning they have the fibroblastic component and they have the epithelial components. But the stromal cells are the clonal and the truly neoplastic pattern. But remember that it is biphasic, there is epithelial and stromal component. They occur in young women in the 20s and 30s. There is the pathogenesis involves the relative increase in estrogen. Okay. Microscopically, they can be solitary, well circumscribed, firm and mobile. Okay. Microscopic, you will see some loose stroma, the fibroblastic stroma, containing this dark light epithelium, but they are compressed by the surrounding fibrous tissue. So that's why you see that it appears like a slit-like opening only. Okay, so they may enlarge late in the menstrual cycle or during pregnancy, and after menopause, they may regress and calcify. So they can grow up to 10 cm in size. So when they are large, they have to be differentiated from another lesion in the breast, which is called Pathology tumor. Okay, so this is the appearance of a fibroadenoma. So they are well circumscribed, cut section are smooth, grayish surface. Okay, morphologically, they are composed of both the stroma and the glandular epithelium. They are still lined by the two types of epithelium, the luminal and myoepithelial, so they are benign. Okay, they appear as a slit-like opening. They are compressed because of the surrounding fibrous tissue or stromal component is proliferating, so they are compressed. That's why they appear like a slit-like opening. Okay. So another lesion in the breast, which is Pathology tumor, these are also biphasic, okay, composed of both the stromal and epithelium, but they are much less common than fibroadenoma. Okay, and it has a spectrum from benign to malignant. So they can form as palpable mass or they can be detected through mammography. Okay, so the changes that are associated with malignancy in Pathology tumor is that there is increase in stromal cellularity, there are cellular anaplasia, high in mitotic activity, rapid increase in size, and infiltrating margins. Okay, most of them, however, are benign and remain localized and are cured by excision. When you have malignant lesion, they can recur, but they also tend to remain localized. Okay. So macroscopically, they are lobulated. They are larger, in the larger spectrum than the fibroadenoma. Okay. Morphologically, they have increased stromal cellularity with pleomorphic cells, and they have a stromal overgrowth like a leaf-like pattern. Okay, so this is a lobular growth. Okay, and this is the glands, the glandular pattern. They appear like a leaf-like pattern. Okay, The stroma are cellular in this below this tumor. Okay, the next benign neoplasm of the breast is an intraductal papilloma. Okay, so they are mostly solitary and found within the lactiferous ducts or the sinuses, and less than 1 centimeter in size mostly. Clinically, patient may present with serous or bloody nipple discharge. Okay, and then you have a small subareolar mass. Okay, and they may present with nipple retraction. So macroscopically, you see delicate branching growth within a dilated duct. Okay. Microscopically, there are multiple papillae, finger-like projection, and we have a connective tissue core, and they are lined by the 2 layers of epithelium, and the luminal and myoepithelial, so they are benign. Okay, so these 2-layer epithelium is important. That determines, that differentiates between benign lesion and malignant lesion. Okay. In malignant lesion, the myoepithelium is lost. Okay, so that's why you don't have the myoepithelium. So that differentiates between benign and malignant lesion. Okay, so next we go to malignant neoplasm in breast carcinoma. So we're going to elaborate a bit more on this because they are very, very important. They are common in our country. The first, the commonest type of cancer among female. Yeah? So according to the National Cancer Registry, they are common. They present with abnormal mammogram or an irregular, rapidly growing mass. And sometimes they can also present with bloody nipple discharge. Okay? And it is the leading cause of female cancer death worldwide. Okay? Most of them are sporadic. Only about 5 to 10% are associated with hereditary cancer susceptibility genes. So this breast cancer, they arises from the epithelial cells at the terminal duct lobular unit. Okay, so from the acini cells. So for every case of breast cancer, it is required to do testing for estrogen and progesterone receptor on this breast cancer. So you need to do a biomarker profile for the estrogen and progesterone receptor, because if they are positive, patients have the option to be treated with tamoxifen. Okay, and then the other marker that needs to be tested are the HER2 oncoprotein. Okay, so this HER2 oncoprotein, if they are positive, okay, patient can be treated with Herceptin. Okay, so this is the type of treatment that can be given, options to the patient if they have these markers. Right? Okay, so based on genetic studies, they do genetic profiling. So breast cancer are divided into 4 molecular classification. Okay, so you have luminal A, luminal B, the HER2 positive, and basal line. So that depends on the pattern of ER positivity and the HER2 positivity. Okay, for example, the basal line ones are showing triple negative, meaning ER negative, PR negative, and HER2 negative. So meaning they are not going to be able to respond to the treatment that is available, and usually this type will be much more aggressive. Okay, so that's why do we bother to classify? Because they have different outcomes and they will require different therapies. Okay, so what are the risk factors for breast cancer? Okay, you have all this geographical distribution, age, okay, increases after the age of 30, family history, those who have first degree like relative with breast cancer will have increased risk in incidence, menstrual history, early menarche, late menopause, just indicating a prolonged exposure of estrogen to the patient. Pregnancy, first live birth from the age of 25 to 29, there is slightly increased risk, okay, and so on. And presence of benign breast disease. As I mentioned earlier, the proliferative pattern of fibrocystic change especially those associated with atypia, will have increased risk of breast cancer. Okay, and other factors such as exogenous estrogen when the patient are given hormone replacement therapy, again this can increase the risk of breast cancer. OCP, oral contraceptive pills, these are not shown to affect the risk of breast cancer. Ionizing radiation, patients who are young, who has been treated with radiotherapy for diseases such as for Hodgkin lymphoma, they have increased risk of breast cancer. But for those women who are treated later in life, the irradiation, the risks are not elevated. Okay? And for those who undergo mammographic screening and they worry that the risk of radiation from the mammography, it is a very low dose radiation that is used during mammography. So there is no significant effect of mammography to the incidence of breast cancer. Okay? So there are also a few less well established factors such as obesity, alcohol consumption, diet high in fat. They have been implicated with increased risk of breast cancer, but mainly related to the exposure of estrogen. So pathogenetically, how does this breast cancer occur? So you need three things that are important in the development of breast cancer. There will be some genetic changes, will be some hormonal influences, and also environmental variables. So talking about genetic changes, again we have mentioned about the HER2 oncoprotein. So this is the best characterized genetic mutation that occurs, that undergoes amplification in patients who have breast cancer. So when patients have this, its overexpression is also associated with poor prognosis. But they do have the treatment for it, okay? And then there are also many other genetic alterations that can occur. So this may give rise to different subtypes of breast cancer, okay? And then roughly a third of patients with hereditary, remember hereditary accounts for 5 to 10% only, but a third of these may have mutation in the BRCA1 and BRCA2. So if you remember yesterday's lecture, so ovarian cancer is also associated with this genetic mutation. Okay? Less common genetic disease, there are some syndromes that are associated with breast cancer, increased risk of breast cancer formation. Right? And those women who have this breast cancer susceptibility gene, they are often having bilateral cancer, both cancer on both sides of the breast. Other familial form of cancer, such as the ovarian cancer, that we see in BRCA1 mutation, they usually have family history, they usually have breast cancer at an earlier age, and they belong to certain ethnic groups. Okay. For hormonal influences, again, it is due to exposure to excess endogenous estrogen. Okay, so the risk factors that are associated with that will increase the risk of breast cancer. Environmental variable, as we have looked at the risk factors just now, you have the geographic areas. Okay, so different geographic areas have different risks of breast cancer. So it may have some geographic differences in the risk for breast cancer. Okay, clinically, breast cancer, they present with painless lump, and you have associated nipple retraction, skin dimpling, ulceration, and orange peel appearance. The skin of the orange, it will appear like that on the skin. Okay, and fixation, which is fixed to the underlying structures, meaning they have already embedded into the underlying muscle or wall of the chest. That means that it has shown invasion. Okay, and sometimes may show calcification, which will be detected on mammography. Okay. Right, so For breast cancer, they will have a poorly defined mass with irregular border, and they may show grayish to white or yellowish appearance. And for benign breast lesion, they usually appear well defined, well circumscribed. So between these two, this is quite irregular lesion of the breast. Here you have a rounded, well circumscribed lesion, which is normally a fibroadenoma. Okay, so classification of breast cancer. Normally they are located in the upper outer quadrant. Okay, and about 4% of women have bilateral tumors. So they are classified according to their invasiveness. So you have non-invasive, which is called ductal carcinoma in situ. So in situ meaning they do not cross the basement membrane. So they are still remain within the basement membrane, no invasion, but their risk for malignancy is high. Okay, so you have the non-invasive pattern, the ductal and the lobular carcinoma in situ, and then you have the invasive type. Okay, the invasive type, the commonest one is the invasive ductal carcinoma. Okay, and then you have many different histological types, the invasive lobular, medullary, colloid, tubular, and other types. Mucinous. Okay, and they arise from the carcinoma, the terminal duct lobule. Okay, so for ductal carcinoma in situ, they tend to fill and distort duct-like spaces. So they have many architectural patterns. They can be solid, they can be cribriform, they can be papillary. Necrosis can be present at the center. So nuclear appearance, they can range from a bland, uniform to pleomorphic changes, and frequently associated with calcification. That's why we commonly detect it in mammography. Okay, but they have an excellent prognosis after a simple mastectomy compared to the invasive type. Lobular in situ, they are lobular carcinoma in situ. They usually expand the lobules but do not alter the acini. So this is the appearance. They look like a normal lobules, but all the acini are filled with the cells. They are monomorphic with bland brown nuclei. Okay, and LCIS is always an incidental finding. They are rarely associated with calcification. Okay, but again, both the ductal carcinoma and lobular carcinoma in situ, they have risk for developing invasive cancer. Okay, the other type of lesion that we have to look at is the Paget's disease of nipple. Okay, this is caused by the extension of the ductal carcinoma in situ up into the lactiferous ducts and into the skin of the nipple. Okay, so you see cells within the stratified squamous epithelium, the overlying skin, individual large cells here. So this is the Paget cells. Okay, and when you have Paget cells within the skin of the nipple, usually they are associated with an underlying breast cancer. Okay, usually we will have that. Okay, the prognosis is based on the underlying carcinoma, but not based on the Paget's disease. Right? So current treatment is with either tamoxifen or they will give herceptin depending on the presence of those biomarkers that we have mentioned earlier, or they may give they may do mastectomy. Okay, for invasive ductal carcinoma, they are the most common type. They are fairly well demarcated and stony hard, but still irregular borders with gritty sensation because they have the calcification. The size may vary microscopically, well to poorly differentiated cells. Okay, so those are the malignant glands. So we call it invasive ductal carcinoma when we see it is used for all carcinoma that cannot be subclassified to the specialized type, because we have the specialized type like the mucinous, the tubular, all those things, but For those that cannot be classified, we put it all together in the invasive ductal carcinoma, and usually associated with DCIS and LCIS. Okay, so you have morphologically, you have tubules, you have pleomorphic cells lining the tubules, or it can be in the form of solid architectures, like we see in the diagram earlier. Okay. About 2/3 of these invasive ductal carcinoma express ER and PR receptors, and about 1/3 overexpress the HER2 oncoproteins. Okay, next one, for the invasive lobular carcinoma, this is less common. They usually forms Indian filing. The morphologically, you see like an Indian files or targetoid appearance around the duct. They can be bilateral. Okay, so what I mentioned as the Indian files just now here is like these cells. They form like an Indian filing. The red Indian, when they go to war, they were arranged in a single file. So this is how the cells are arranged in the single files. That's why they are described as that. Okay. Alright. So the cells in lobular carcinoma are identical to the cells in the lobular carcinoma in situ. Usually they have associated lobular carcinoma in situ. And they are associated with the presence of mutations in the E-cadherin, which is the surface protein that contributes to the cohesion of normal breast epithelial cells. So when they are lost, the cohesion are less, that's not present. So cell will be more of in a single house. Okay, more in a single. They do not connect with each other. Okay, for the other types, the histological type, you have mucinous carcinoma, which can be present with gelatinous mass. So you see cells within an extracellular mucin. So this pale bluish structure here, those are mucinous material, and the malignant cells will be seen floating inside this mucinous material. This specialized type of breast cancer have a favorable prognosis. And then we have the tubular carcinoma. They are characterized by a well-formed angulated gland. So you can see the glands that are a bit angulated, but they are lined by just a single layer of cells. But this type of cancer has the best prognosis. Okay. So how does the breast cancer spread? Okay. They tend to spread to the surrounding structures. For direct local invasion, they tend to spread to the pectoral muscles or the deep fascia of the chest wall, or they can spread to the overlying skin. Okay, and involvement of the lymphatic pathways can result in localized lymphedema. So this is what you see at the pseudo-orange or orange pale changes in the skin. Okay, they can spread to the lymph nodes, to the axillary lymph nodes or the internal memory, and they can metastasize hematogenously to the lung, bones, liver, and brain. Okay, so for breast cancer, it is important for us to grade them. We use the modified Bloom and Richardson grading system that is characterized by the tubular formation, nuclear pleomorphism, and mitotic figure. So these are the three things that we use to grade breast cancer. So they are very important. And you give a score to it, and if you have a score of 8 to 9, then the grading of this cancer is grade 3. Okay. So for each component, that you give 1 to 3 points. Okay. So tubular formation or solid formation. Okay. Nuclear pleomorphism, mild, moderate, severe, mitosis. If the number of mitosis is less than 10, more than 10 to 20, more than 20. Right. So that's how we grade them. Okay. So these are some features showing mitosis in the malignant cells. This is showing tubular formation. In this picture here, no tubular formation is seen, okay, because they just form like nest, there's no lumen there. Okay, so the score will be higher for that. Right? And then nuclear polymorphism, variation in the size and the shape of the cells. Okay, so based on that, we grade them. Yeah? Okay, so this is basically what I have described earlier, so you can have a look later on how the grading is done. Yeah. Staging, we stage the tumor because we want to determine the extent of spread of this breast cancer. Okay, so size is important. That's why when you describe anything, any tumor masses, you have to measure the size, because size is used in the grading, in the staging of some types of cancer. Okay. So this is the staging system that we use, the TNM staging system, T for tumor, N for nodes, M for metastasis. Okay, so we look at prognostic factors for breast cancer. So there are several things. The size, as I mentioned, the histological types. As I mentioned earlier, the tubular, mucinous type, they tend to have a favorable prognosis. Lymph node involvement, okay, is in the staging. Lymphovascular invasion, stage, presence of distant metastasis. These are the prognostic factors for breast cancer. And then we have predictive factors in which for every breast cancer that we diagnose, we need to do, as I mentioned earlier, the biomarker profile we need to do for the estrogen and progesterone receptor, as well as the HER2 oncoprotein receptor. So we have to test for that. If they are positive, they can be treated with some treatment, a specific treatment like tamoxifen for the hormones and the Herceptin for the HER2 oncoprotein. So that's why they are called predictive factors, because it predicts their response to the treatment. Yeah? Okay, so for overall management, surgical form of management is usually the case. So they can do mastectomy with axillary clearance, meaning they remove the breast with the axillary lymph nodes together with it. Or if it's a low grade and very localized and small, they can only do, without the lymphovascular invasion, they can do only a wide local excision without removing the breast, the whole breast. Or they can do hook wire localization. Okay. They can give adjuvant treatment, the chemoradiotherapy, hormonal treatment, tamoxifen if patient has estrogen and progesterone receptor positive, or they can give Herceptin or trastuzumab for HER2 oncoprotein positive. Alright, so that's for breast cancer, primary breast cancer that arises from the breast ductules. Okay, but there are other types of tumors that can arise from the cells that are present inside the breast. Remember, the breast also have inflammatory cells, they also have fat cells, they also have small muscle cells. So tumor can also arise from those components. So you can get lymphoma and you can get sarcomatous malignancy in the breast as well. Okay, so you can get angiosarcoma, tumor that arises from the blood vessels in the breast. Okay, or you can get metastasis from other organs that metastasize to the breast. Okay, so it is still possible. Okay, so for diagnosis, when a patient came to you, there will be palpable mass, ultrasound looks suspicious, or mammography shows areas of high density. So fine needle aspiration can be done, okay, or they can do biopsy, take a biopsy for confirmation, right? So how do you do fine needle aspiration? You just use the normal syringe with a 22 to 26 gauge needle. You can extract the cells from the lesion, okay? And then you can smear it on the slide, and we can assess the cells on the slide, okay? So this is how we see the cells on the slide for fine needle cytology. Okay? So they will show only the cytology the features, okay? But it needs to be confirmed with a tissue biopsy, because you only see the changes like the pleomorphism, the hyperchromatism, but you don't see the features of invasion. Okay? On cytology, you cannot see the architecture, so it's difficult to differentiate between the in situ and the invasive lesion. Okay? So in order to confirm that, you can do a tissue core biopsy that you can evaluate for invasion. So you use this core needle, take a true cut, do a true cut biopsy, and you get a tissue core needle which you need to fix in formalin. Yeah? You have to fix in formalin. Bila you jadi houseman nanti, you have to know this needs to be fixed in a formalin and sent to the lab. If you don't put it in formalin, the specimen will be rejected. And this is a very special specimen. It's not easy to get, right? So, tissue core biopsy need to put in formalin, and it will be sent to the lab to process, to form a slide, and they will make into a slide like this.
Marijuana.
So, if you compare between the cytology just now and here, you have a core tissue biopsy, so you can see evidence of invasion. Okay, so in core tissue biopsy. So this is all malignant cells invading into the stroma. Right? Okay, alright. For male breast, you can get gynecomastia. So this is simply an enlargement of the male breast. Okay, it can occur at any age. They can be unilateral or bilateral. So they can present as button-like subareolar enlargement. And usually they tend to be associated with hyperestrogenemia, for example, in cases like liver cirrhosis, in those who use drugs such as marijuana or heroin, or they are on antiretroviral therapy, or patients who are on anabolic steroids. Okay, so you can get this gynecomastia. And they are associated with small risk of malignancy, but cancer in male breast is very bad, but they do occur. Okay? Alright? Okay, so in summary, for breast pathology of the breast, you need to know the ranges of pathology that can occur. So you have congenital anomaly, so you need to know the age of the patient. So this congenital anomaly tends to occur in younger patient, and know the risk of malignancy is benign activation. Okay, when you have a part of the lungs, so differential ranges of non-neoplastic in neoplastic lesion. So you have to confirm them with fine needle cytology or they know the risk factors in breast cancer, the types of carcinoma, you have the in situ and the invasive component. And different histological types, they are associated with different prognosis. Grading is important, staging is also important, okay? And know about the prognostic and fertility factors and how you manage, so what can be done in terms of the FNAC and biopsy, what can be done to the patient. Alright? Okay, I think that's all. Is there any questions for the pathology
I
of
think it's
breast?
mammogram.
Tak ada? Okay, thank you.
Thank you, doctor. Thank you, doctor.
Thank you, doktor. Pada pipi kan.
Cepat.